Seniors, what's the best blood pressure for older adults? Know the truth. Barbara O'Neill. 3 weeks ago, groundbreaking research emerged, poised to ignite significant controversy and potential frustration within the medical community. This new data unequivocally demonstrates that the long-standing medical consensus regarding blood pressure management has been fundamentally flawed for many decades, particularly when it comes to older adults. For countless years, patients have consistently received the same directive from their physicians: strive to achieve a blood pressure reading of 120/80. This number has been universally heralded as the gold standard, the epitome of perfect cardiovascular health, with the pervasive belief that lower is always better. However, this meticulously conducted research, which involved tracking an astonishing 15,000 seniors aged 75 and above over an extended period, has unearthed profoundly shocking findings that challenge this deeply entrenched paradigm. The study revealed a stark and counterintuitive reality. Those older adults who successfully achieved and maintained the seemingly perfect target of 120/80 actually experienced significantly higher rates of adverse health events. These included a greater incidence of falls, a tragically increased number of fractures, and, most critically, a higher overall mortality rate compared to their counterparts who consistently maintained blood pressure readings above this traditionally recommended threshold. This revelation sends ripples of concern through established medical practices, compelling a reevaluation of what truly constitutes optimal blood pressure for an aging population. I am Dr. Barbara O'Neill, and I have witnessed firsthand the devastating consequences of this outdated approach. I recall vividly the case of a 78-year-old woman named Margaret, whose life tragically ended just 6 months after her doctor diligently guided her blood pressure down to that supposedly perfect 120/80. Margaret's decline was swift and unforgiving. She suffered a debilitating fall, resulting in a severe hip fracture. From that point onward, she never fully recovered her previous independence or vitality. Her passing was not due to a heart attack, nor a stroke, the very conditions these aggressive blood pressure targets were meant to prevent. Instead, it was a direct consequence of blood pressure that was simply too low for her aged body to sustain safely. By the conclusion of this comprehensive discussion, you will possess the critical knowledge of the specific blood pressure range that is genuinely safe and appropriate for your age group, a range that holds the profound potential to safeguard your life and preserve your well-being. However, I will not immediately disclose that precise numerical range. There's a deliberate reason for this withholding. If I were to reveal it at this moment, some of you might simply jot down the numbers and discontinue watching, missing the crucial context. It is absolutely imperative that you grasp the fundamental physiological reasons why this target number fundamentally differs for seniors. You must fully comprehend the cascade of detrimental events that can unfold when blood pressure descends too low in older adults. You need the complete picture before I furnish you with the exact blood pressure range that your physician should realistically be aiming for in your personalized care plan. Before we delve deeper into this vital information, I urge you to pause and consider someone in your life who might be unwittingly endangered by these outdated guidelines. Perhaps it's your beloved mother who frequently complains of debilitating dizziness, an ever-present side effect often attributed to the continuous addition of new blood pressure medications. Or perhaps your father who experienced a worrisome fall just last month, with its true cause potentially masked by conventional medical wisdom. It could even be a dear friend who finds themselves unable to stand securely without instinctively reaching for and clutching onto nearby furniture, their independence slowly eroding due to an unrecognized medical issue. This information is not merely academic, it has real-world, life-saving implications. I implore you to share this video with them right now. Furthermore, I encourage you to subscribe to this channel, as the insights I am about to impart could quite literally serve as a lifeline, preventing preventable tragedies and profoundly improving the quality of life for countless seniors. Let me now recount Margaret's complete story, not just as a cautionary tale, but as an illuminating narrative that will fundamentally reshape your perception of blood pressure management forever. I first encountered Margaret when she was 78 years old. For a decade prior, she had been diligently navigating the complexities of managing high blood pressure. Her journey began at the age of 68 when she received her initial diagnosis with a blood pressure reading of 152/88. While this reading was considered elevated, it certainly wasn't dangerously high. Nevertheless, her doctor, adhering strictly to prevailing guidelines, promptly initiated medication. Within 2 months, her pressure showed commendable improvement, dropping to 138/82. Her doctor expressed satisfaction, noting the good progress, but immediately pivoted to the standard mantra: "We still need to get you to 120/80. That's the established standard. That's the ideal number where you'll be safest from the risks of heart attacks and strokes." In pursuit of this target, he subsequently increased her medication dosage. 2 months later, Margaret's blood pressure stood at 128/76. Progress was undeniable, yet still not the goal. The 120/80 benchmark remained elusive. Undeterred, her doctor prescribed a second medication, emphasizing, "We really want you at that ideal number." Every medical guideline unequivocally states that 120/80 is the definitive target. Margaret, a loyal patient for 2 decades, placed implicit trust in her doctor. He had always guided her wisely, and if he asserted that 120/80 was the ultimate objective, she wholeheartedly believed him. She faithfully adhered to her dual medication regimen, meticulously monitoring her blood pressure at home on a regular basis. After another 2 months of diligent effort, her pressure finally reached 122/78, almost perfect. Her doctor was visibly thrilled, exclaiming, "This is exactly where we want you. Keep doing precisely what you're doing." Initially, Margaret felt perfectly fine, perhaps a touch more fatigued than usual, but at 78, a degree of tiredness seemed entirely normal and acceptable. Then, a peculiar and unsettling symptom began to manifest. Whenever she transitioned from a sitting to a standing position, she would experience a momentary wave of dizziness, lasting just a few seconds. The room would subtly spin, forcing her to instinctively grasp onto whatever was nearby until the sensation subsided. During her subsequent checkup, she cautiously mentioned this new phenomenon to her doctor. His response was dismissive. "That's probably just age-related," he reassured her. "Your blood vessels aren't as elastic as they once were. It simply takes a moment for your blood pressure to adjust when you change positions. It's completely normal for your age. Just make sure you stand up slowly. Take your time." Margaret, ever compliant, adopted his advice. She began to stand up with extreme slowness and meticulous care. Yet, the dizziness persisted, occurring every single time. She rose. Every morning when she got out of bed, every time she lifted herself from the couch, the unsettling spinning sensation became an unwelcome constant. At this juncture, I invite you to reflect on your own blood pressure readings and age. Consider if you've experienced similar symptoms. Understanding the collective data is crucial for appreciating the widespread nature of this issue. For instance, a reading of 145/85 at age 72 or 128/76 at age 68 provides valuable insight into the ranges people are currently experiencing. The information I am about to share is absolutely critical. Building upon these real-world observations, the persistent dizziness began to erode Margaret's confidence, fostering a growing sense of anxiety about the simple act of standing. She would often sit for prolonged periods, mentally steeling herself and preparing for the inevitable sensation before attempting to rise. During a visit, her daughter noticed this troubling change. "Mom," she inquired, her voice tinged with concern, "why are you moving as if you're afraid of something? What's happening?" Margaret, with a heavy heart, explained the pervasive dizziness. Her daughter, deeply worried, insisted, "You need to tell your doctor this is getting worse." Margaret followed through, calling the doctor's office and leaving a detailed message. The nurse returned her call the following day, relaying the doctor's assessment. As long as your blood pressure numbers remain good, the dizziness is likely just a normal part of aging. Make sure you're drinking enough water throughout the day. That can sometimes help with lightheadedness. The dizziness, however, relentlessly continued, unaffected by these reassurances or recommendations. Then, one fateful morning, approximately 3 months after her blood pressure had been successfully lowered to that perfect 122/78, Margaret awoke at 3 a.m., needing to use the bathroom. She sat up in bed, carefully swung her legs over the side, and then attempted to stand. This time, the room spun violently, a sensation far more intense and disorienting than any she had experienced before. She felt her knees buckle uncontrollably beneath her. Desperately, she reached out for the nightstand, but her hand missed its mark entirely. She fell hard, her right hip slamming with brutal force into the sharp corner of the nightstand on her way down. She landed on the floor with a sickening crash, unable to move, utterly helpless. The pain radiating from her hip was absolutely excruciating, a searing agony that immobilized her. Her husband, startled awake by the jarring sound, rushed into the bedroom to find Margaret on the floor, weeping, completely unable to move her right leg. Without hesitation, he immediately dialed 911. The paramedics arrived within minutes, their swift response a testament to the urgency of the situation. Their first action was to check her blood pressure as she lay on the floor, a reading of 118/74. With utmost care, they then helped her to a sitting position and checked it again, 94/62. Finally supporting her gently, they helped her stand and took a third reading, 82/54. The lead paramedic, seasoned and experienced, immediately understood the grave implications of these rapidly plummeting numbers. "Ma'am," he explained with calm authority, "your blood pressure is dropping dramatically every time you change positions. The medications you're taking have gotten your pressure so low that your body simply cannot maintain adequate pressure when you stand up. Your brain wasn't getting enough blood flow. That's precisely what caused the dizziness, and that's ultimately what led to this severe fall." At the hospital, X-rays tragically confirmed everyone's worst fears: a severely fractured hip, broken completely through. There was no alternative. Margaret would require major surgery, a full hip replacement. However, at 78 years old, surgery of this magnitude carried enormous inherent risks. The potential complications were numerous and daunting: infection, dangerous blood clots, pneumonia, the risk of stroke during anesthesia, and a host of other complications stemming from prolonged immobility during recovery. Yet the orthopedic surgeon conveyed the grim reality: there was no choice. Without surgical intervention, Margaret would never regain the ability to walk again, ever. The operation was scheduled for the very next morning. The surgery itself, remarkably, proceeded without incident. There were no complications during the actual procedure. However, the subsequent recovery proved to be brutal, an arduous and soul-crushing ordeal. Margaret spent a full week recuperating in the hospital, followed by 3 weeks in an intensive rehabilitation facility. There, she endured twice-daily physical therapy sessions, painfully and exhaustingly striving to relearn the most basic act of walking. Before the fall, she had been a fiercely independent woman, living comfortably in her own home, preparing her own meals, driving to the grocery store, and regularly visiting friends. Now, she found herself dependent on others for virtually every aspect of her daily life: assistance with dressing, help with bathing, and even support to walk from one room to another. She felt as though she had aged 2 decades in a single, devastating night. When Margaret finally returned home after 4 emotionally and physically draining weeks, she was a shadow of her former self. She was gripped by a profound terror, paralyzed by the fear of walking without her trusty walker, terrified of being left alone lest she suffer another fall. The simple act of moving too quickly sent shivers of dread through her. Her devoted daughter had to temporarily move in to provide constant care and assistance with daily tasks. Margaret's entire world, once vibrant and expansive, had drastically shrunk. Prior to the fall, she had been an active and engaged member of her community. Weekly trips to the grocery store, faithful attendance at Sunday church services, regular lunches with cherished friends, and lively book club meetings. Now, she barely ventured outside the confines of her home, too afraid, too weak, too fragile to face the outside world. But it is at this juncture that Margaret's story takes an even more truly heartbreaking turn. 6 months after her life-altering fall, Margaret developed pneumonia. The prolonged period she spent sitting in chairs and lying in bed, immobilized by fear and limited mobility, had led to a dangerous accumulation of fluid in her lungs. Pneumonia in a 79-year-old individual with severely reduced mobility is an exceedingly perilous condition, all too often proving fatal. Margaret was rushed back to the hospital, where she was immediately given intravenous antibiotics and placed on oxygen. Despite these intensive medical interventions, her weakened lungs simply could not clear the relentless infection. Her body, already too weak, too deconditioned from 6 months of severely restricted movement and the pervasive grip of fear, simply gave out. Margaret died 3 days after being admitted to the hospital. Her daughter was utterly devastated, consumed by a profound grief mingled with an equally powerful fury. Mom was completely fine before they lowered her blood pressure so aggressively, she recounted to me through a torrent of tears. She was active, independent, and genuinely happy with her life. Then they got her to that magic number of 120/80, and everything just completely fell apart. She started getting dizzy, then she fell. That single fall initiated a tragic cascade of decline that ultimately culminated in her death, all because her blood pressure was too low, but her doctor kept insisting that 120/80 was perfect. How can a perfect number take someone's life? That, precisely, is the quintessential question that demands an answer. How can a supposedly perfect, universally endorsed blood pressure number become a lethal factor? The undeniable and deeply unsettling answer is that 120/80 is unequivocally not perfect for everyone. In fact, for seniors, especially those over the age of 65, striving to achieve this precise numerical target can be outright dangerous. It can precipitate the very sequence of tragic events that befell Margaret. The insidious onset of dizziness, a heightened risk of falls, the agony of fractures, a precipitous decline in overall health and independence, and ultimately, a premature death. I encourage anyone who frequently experiences dizziness when standing up to take this as an extremely serious warning. If this unsettling sensation is a regular occurrence for you, it is a critical indication that your blood pressure might be dangerously low for your specific age and physiological state. Your body is, quite literally, screaming at you, signaling that something is profoundly amiss and demands immediate attention. Margaret's death, in retrospect, was entirely preventable. Had her doctor possessed the crucial understanding that 120/80 was simply too low for a 78-year-old woman, had he instead been targeting a more appropriate, higher number, Margaret would, in all likelihood, still be alive today. She would still be walking with confidence, still maintaining her cherished independence, and still joyfully embracing her grandchildren. But he didn't know. He was rigidly adhering to outdated, generalized guidelines. Directives that tragically fail to account for the nuanced, age-related physiological changes that occur within the human body. These guidelines, in their inflexible application, treat the delicate, evolving physiology of an 80-year-old body precisely the same as that of a robust 40-year-old body, a fundamental flaw that can have catastrophic consequences. So, what then is the truly correct blood pressure for seniors? What is the specific number, or more accurately, the specific range that you should genuinely be aiming for to ensure both longevity and quality of life? I am now prepared to disclose those exact ranges. However, before doing so, it is absolutely essential that you fully comprehend why seniors are physiologically distinct and why the standard one-size-fits-all rules simply do not and cannot apply to older adults. The first profound reason for this physiological divergence lies in the progressive stiffening of blood vessels. As you advance in age, your arteries naturally undergo a transformative process. becoming progressively less elastic and more rigid. This phenomenon, scientifically termed arteriosclerosis, is not a disease in itself, but rather a completely normal, unavoidable aspect of the aging process. It affects everyone to varying degrees. Unlike the supple, flexible arteries of youth, stiff arteries are significantly less capable of expanding and contracting with the dynamic ease required for optimal blood flow. To illustrate, consider the stark contrast between a brand new, highly elastic rubber band and an old, dried-out, brittle one. When your heart propels blood through your circulatory system, stiff arteries simply cannot absorb and efficiently distribute the pressure wave generated by each heartbeat as effectively as their young, pliable counterparts. This fundamental change necessitates a slightly higher baseline blood pressure to adequately maintain consistent and sufficient blood flow to all your vital organs. This is particularly crucial for your brain, which, situated at the apex of your body, must continuously defy the constant pull of gravity to receive the necessary perfusion. In a younger individual, blessed with flexible, elastic arteries, a reading of 120/80 provides ample pressure to ensure excellent blood flow to the brain, even when transitioning to an upright standing position. However, in an older person whose arteries have become stiff and rigid, 120/80 may prove utterly insufficient to provide that necessary pressure. When they stand up, their inflexible vessels cannot rapidly adjust to the sudden gravitational shift, leading to a sharp, precipitous drop in blood pressure. Consequently, blood flow to the brain decreases abruptly, triggering dizziness, a loss of balance, and, all too often, a dangerous fall. The second critical reason for the unique physiological needs of seniors stems from a decreased sensitivity of specialized internal sensors. Embedded within the walls of your blood vessels are remarkable sensors known as baroreceptors. These miniature biological monitors are tirelessly at work, constantly detecting even subtle changes in blood pressure. Upon detection, they transmit rapid, urgent signals to your brain, prompting instantaneous adjustments in your heart rate and the degree of vessel constriction. In young, healthy individuals, these baroreceptors operate with astonishing efficiency, responding within a mere fraction of a second. Thus, when a young person stands up, their baroreceptors immediately perceive the slight gravitational drop in pressure and instantly instruct the heart to beat a little faster, simultaneously signaling the blood vessels to constrict ever so slightly. This automatic rapid response serves to maintain stable blood pressure, thereby preempting any sensation of dizziness. However, a fundamental change occurs with age. Baroreceptors become significantly less sensitive, and their response time dramatically lengthens, akin to reflexes that have dulled and slowed over the passage of time. Consequently, when an older adult stands up, their sluggish baroreceptors simply cannot react quickly enough to the sudden gravitational challenge. If their baseline blood pressure is already hovering on the lower side, perhaps at the ideal 120/80, and their baroreceptors are slow to initiate compensatory action, they will inevitably experience a dangerous and prolonged pressure drop lasting for several critical seconds before their body finally manages to compensate. This delayed response is precisely what clinicians refer to as orthostatic hypotension, and it is a direct, insidious cause of falls among the elderly. The third, equally critical reason involves altered medication sensitivity in older adults. The physiological processes by which older individuals metabolize and eliminate medications differ profoundly from those in younger people. Kidney function naturally experiences a gradual decline with age, diminishing its efficiency in filtering and excreting drugs. Liver function, too, can become less robust. Furthermore, body fat percentage tends to increase, and total body water content often decreases. All these interconnected physiological factors collectively mean that medications tend to linger in an older person's system for much longer durations and, crucially, exert significantly stronger and more prolonged effects. A precise dosage of blood pressure medication that is deemed perfectly appropriate and safe for a healthy, vibrant 50-year-old might, in stark contrast, prove to be dangerously potent for an 80-year-old taking the exact same pill. The older adult, in such a scenario, is far more susceptible to experiencing excessive, potentially dangerous blood pressure lowering, levels that are simply too low, dramatically too low, for their body to safely handle and maintain stability. The fourth compelling reason why older adults necessitate distinct blood pressure targets lies in the fundamentally different spectrum of health risks they confront. In younger individuals, the primary long-term danger associated with chronic high blood pressure is the cumulative, insidious damage it inflicts over many decades. This includes the gradual deterioration of the heart muscle, progressive impairment of kidney function, and microscopic damage to the delicate blood vessels within the brain, ultimately culminating in slowly developing heart disease or kidney disease that progresses over many years. However, in older adults, the immediate tangible risk posed by excessively low blood pressure can remarkably far outweigh the theoretical long-term risk associated with moderately elevated pressure. A single serious fall directly precipitated by dangerously low blood pressure possesses the potential to tragically claim the life of an 80-year-old individual within a mere matter of months, as tragically exemplified by Margaret's story. Conversely, a blood pressure reading consistently hovering around 140/85 might not induce any problems whatsoever for many years, or quite possibly ever. Therefore, the entire risk-benefit calculation, the careful weighing of potential harms against potential advantages, fundamentally shifts and changes dramatically with advancing age. For a 50-year-old, with several decades of life potentially stretching ahead, aggressively targeting that 120/80 threshold makes perfect, logical sense, as preventing long-term organ damage is of paramount importance. But for an 80-year-old, the immediate, overwhelming priority shifts to preventing a catastrophic fall, an event that could instantaneously strip away their cherished independence or tragically end their life. This immediate concern might, and often does, far outweigh the importance of hitting some abstract, theoretical, perfect number meticulously recorded on a medical chart. I recognize that at this juncture, many of you are undoubtedly desperate to ascertain the actual numerical targets. What, precisely, should your blood pressure aim be if you are 65 or 75 or even 85? I am indeed going to provide you with those specific age-appropriate ranges, but first, it is absolutely paramount that we examine what the most current and robust research unequivocally demonstrates. Because, as you will discover, the research findings are not only surprising, but directly contradict what the vast majority of doctors have been conventionally taught throughout their medical training, and what, regrettably, they continue to communicate to their patients every single day. The traditional medical guideline, the one that rigidly dictates everyone, irrespective of their age, should meticulously aim for a blood pressure of 120/80, originated from extensive studies. These seminal studies were primarily conducted on cohorts of middle-aged adults, individuals typically in their 40s, 50s, and early 60s. Within this specific demographic, these studies very clearly and convincingly demonstrated that achieving and maintaining lower blood pressure significantly diminishes the long-term risk of heart attack and stroke. And for middle-aged individuals, that particular finding remains absolutely and unequivocally true. However, here lies the critical and often overlooked problem. A vanishingly small number of these landmark studies specifically focused on or included a sufficient representation of individuals over the age of 75 or even over 80. Consequently, they simply did not encompass enough very old adults to draw statistically reliable, age-specific conclusions. And the limited handful of subsequent studies that did specifically examine older adults uncovered something completely unexpected and profoundly counterintuitive, a finding that directly challenges and even overturns decades of deeply ingrained medical dogma. Recent, large-scale research has diligently tracked thousands of real-world older adults, specifically those over 75 years of age. Crucially, this research did not involve a cherry-picked group of exceptionally healthy seniors. Rather, it encompassed typical older adults, including those grappling with pre-existing conditions such as diabetes, a history of prior strokes, chronic kidney disease, and varying degrees of frailty. These individuals were followed for many years, and their health outcomes were meticulously compared based on their average blood pressure readings over time. The results, as previously hinted, were nothing short of shocking and revolutionary within the medical community. Among this demographic of adults over 75, those who consistently maintained a systolic blood pressure, the top number, between 130 and 140, exhibited the absolute lowest mortality rates. This specific group experienced significantly lower death rates, not only compared to those whose pressure consistently fell below 120, but also when compared to those with pressure readings consistently above 150. Delving deeper into the data, the group whose systolic pressure was consistently running below 120 showed a measurably increased risk of debilitating falls, alarming fainting episodes, the onset of acute kidney injury, higher rates of hospitalizations for various ailments, and ultimately a greater overall risk of death. Conversely, the group whose systolic pressure was consistently above 150 demonstrated increased risks of stroke and heart attack, which wasn't surprising and aligned more closely with traditional expectations. But the truly illuminating finding was the identification of a sweet spot, a particular blood pressure range, definitively associated with the longest survival and the best overall quality of life. This optimal range was solidly situated within that 130 to 140 systolic bracket, not the long-held target of 120, and certainly not an even lower 110, but rather a range notably higher, 130 to 140. The researchers involved in these studies expressed genuine surprise at these compelling findings. This evidence directly contradicted virtually everything they had been meticulously taught throughout their medical careers. However, upon more careful analysis of the extensive data and a deeper reconsideration of the underlying physiology, these findings, in fact, made perfect and logical sense. For older adults, whose arteries are inherently stiffer and whose physiological reflexes are naturally slower, maintaining a blood pressure moderately higher than the traditional youthful target actually provided better, more consistent, and more reliable blood flow to vital organs, with particular emphasis on the brain. This subtly higher pressure effectively prevented the dangerous and precipitous drops in pressure that so often occur upon standing, thereby dramatically reducing the debilitating risk of falls. These very real, immediate, and tangible benefits for quality of life and safety clearly and demonstrably outweighed any theoretical, small increase in long-term cardiovascular risk that might be associated with running slightly higher numbers. Despite this compelling research, I am still holding back on providing your precise, specific target number. This is because it is crucial to understand that it's not a single, identical number for every single person. The ideal blood pressure target is a highly individualized metric, profoundly dependent on a unique constellation of personal factors. Your specific age, the presence or absence of other medical conditions, your overall level of health and fitness, whether you are robust and active or more frail, and your personal tolerance to medication effects. The ideal number for a generally healthy and active 68-year-old, for instance, will naturally differ somewhat from the ideal number for an 82-year-old who is frail and grappling with multiple chronic illnesses. To vividly illustrate this crucial point of individualization, allow me to share the contrasting experiences of two distinct patients, Harold and Ruth. Harold was 72 years old when I first encountered him in my practice. For several years, his blood pressure had consistently hovered around 146/88. His primary care physician, steadfastly adhering to the prevailing guidelines, was determined to lower it, striving to bring him down to the standard 120/80 target. Consequently, Harold was started on blood pressure medication. After a mere 2 months of this treatment, his pressure had indeed dropped to 124/78, tantalizingly close to the prescribed goal. Mission accomplished, his doctor might have declared. Yet nothing could have been further from the truth. Harold felt absolutely terrible. He was constantly fatigued, plagued by an overwhelming sense of exhaustion that sapped his energy. He experienced debilitating dizziness every single time he stood up, forcing him to move cautiously. He found it impossible to concentrate on anything, his brain perpetually feeling foggy and unclear. His previously vibrant quality of life had completely collapsed, replaced by a pervasive sense of malaise and impairment. I undertook a careful and thorough review of Harold's complete medical history. Beyond his blood pressure, he was remarkably otherwise exceptionally healthy for a 72-year-old man. He led a very active lifestyle, had no history of diabetes, no underlying heart disease, and his kidney function was excellent for his age. For an individual like Harold, his initial blood pressure of 146/88 was, in all probability, not dangerous at all. It was likely an appropriate baseline for his physiology, and the prescribed medications were unequivocally causing severe, unacceptable side effects that were dramatically diminishing his quality of life. In response, we carefully and systematically reduced his medication dosage, allowing his blood pressure to gradually and naturally return to a more suitable level, settling around 136/82. Within 2 short weeks, Harold felt dramatically better. His energy levels completely rebounded, the incessant dizziness totally disappeared, and his mind felt clear and sharp once again. His blood pressure of 136/82, while moderately higher than the textbook target of 120/80, was not only perfectly safe and appropriate, but also profoundly beneficial for a healthy, active 72-year-old man like Harold, restoring his vitality and independence. Now, let me introduce you to Ruth, whose case illustrates the complete opposite end of the spectrum, further underscoring the vital principle of individualized care. Ruth was 83 years old, notably frail, and contended with multiple serious medical problems: chronic heart failure, long-standing diabetes, and advanced chronic kidney disease. Her blood pressure readings consistently hovered around 168/92, a level that was, by any conventional measure, definitely elevated. Her cardiologist, following standard protocols, advocated for an aggressive approach to lower her blood pressure, employing multiple medications. However, I strongly disagreed with this particular strategy. For Ruth, given her highly specific and complex medical situation, aggressively lowering her blood pressure carried a far greater risk of doing more harm than good. She was already quite weak, her gait was notably unsteady, and she was already categorized as being at an extremely high risk for serious, debilitating falls. Significantly reducing her blood pressure with powerful medications could very easily push her over the precarious edge, precipitating a catastrophic fall with potentially fatal consequences. After careful consideration and extensive discussion, we made the deliberate and informed decision to maintain Ruth's blood pressure at approximately 160/90. This reading was undeniably higher than traditional textbook targets. However, for Ruth, taking into account her advanced age, her inherent frailty, her multitude of compounding health problems, and her pronounced fall risk, this approach was unequivocally the safest and most compassionate choice. She remained remarkably stable, experiencing no falls, and avoiding any further hospitalizations directly attributable to her blood pressure. Her precious quality of life, fragile as it was meticulously preserved. 5 years later, Ruth was still alive, still residing independently in her own home, and still managing her daily activities with a commendable degree of autonomy. Her blood pressure had remained consistently steady around 160/90 throughout that entire period. I firmly believe that if we had aggressively pushed to lower her blood pressure down to the 120/80 standard, Ruth would have, without a doubt, suffered a fall within a matter of months, likely fractured something severe, and quite possibly succumbed much sooner. Reflecting on Harold and Ruth's diverse experiences, it becomes evident that individual health profiles profoundly influence optimal blood pressure targets. Consider your own circumstances. Are you 72 with diabetes, 68 with no major illnesses, or 80 with kidney disease? Understanding these individual health factors is essential for grasping the complete picture of personalized blood pressure management. Now, let me illuminate a truly important distinction regarding systolic versus diastolic blood pressure, as most individuals do not fully grasp the crucial differences between these two numbers. the majority of discussions and guidelines concerning blood pressure targets tend to focus almost exclusively on the systolic reading, which is the top number. This represents the peak pressure measurement exerted when your heart muscle actively contracts, forcefully pumping blood out into your arteries. Diastolic pressure, conversely, is the bottom number, and it measures the pressure remaining in your arteries when your heart muscle relaxes completely between beats, allowing the chambers to refill with blood. For older adults, systolic pressure typically holds significantly more clinical importance than diastolic pressure in the majority of cases. As you age, systolic pressure naturally exhibits a tendency to rise, primarily as a direct consequence of the progressive stiffening of the arteries we discussed earlier. However, diastolic pressure often remains relatively stable, or in some instances may even show a slight decrease. This divergence in behavior between the two numbers leads to a phenomenon doctors refer to as a widened pulse pressure. This is the mathematical difference between your systolic and diastolic readings, and it tends to progressively increase with age. For example, a typical 70-year-old might exhibit a blood pressure reading of 150/75. This translates to a pulse pressure, the difference between a 150 and 75, of 75 points. Critically, this pattern is entirely normal and expected for that age group, simply reflecting the natural age-related stiffness of the arterial walls. What is absolutely undesirable and potentially dangerous in older adults, however, is a very low diastolic pressure. If the diastolic reading drops significantly below 60, it can critically reduce blood flow to the heart muscle itself during the vital relaxation phase between beats. This insufficient perfusion to the heart muscle can precipitate serious cardiac problems, potentially leading to angina, arrhythmias, or even heart attack symptoms. Recalling Margaret's tragic fall, her blood pressure when she collapsed was 122/78 while lying down. Her systolic pressure of 122 was already lower than what would be considered ideal for a 78-year-old woman. However, her diastolic reading of 78 was, in isolation, actually within an acceptable range. The true and alarming problem became glaringly apparent when she attempted to stand up. Her systolic pressure crashed dramatically down to a mere 82, and her diastolic pressure plummeted to a critically low 54. A diastolic pressure of only 54 is not merely low, it is dangerously, critically low. At such a profoundly reduced pressure, her heart muscle was not receiving adequate blood flow during its crucial relaxation phase, and her brain was certainly not getting nearly enough blood flow to maintain consciousness while standing upright. This severe and precipitous drop directly caused her devastating dizziness, her loss of balance, and ultimately her fatal fall. Let us now delve deeper into the intricate